Today we'd like to welcome back Dr. Angelina Edwards. Some of you may already be aware she's presently doing a fellowship in transplant nephrology at Washington University in St. Louis and has been here interviewing for a position on the transplant service as a new transplant nephrologist. This is her second visit now. She grew up in El Paso, went to med school. Where did you go undergrad again?
At Texas, undergrad at UTEP.
Okay, UTEP. What's
Go
their?
Miners.
What are they?
The Miners.
Oh, the Miners.
Yeah, it used to be College of Mines before it was.
Miners. So they're all under 18 if they're the Miners. You guys didn't get that joke.
That was a good one.
Med school in Houston at UT and did her medicine and nephrology in Houston, and now once again transplant nephrology fellowship in St. Louis at Washington University. And they have a fairly aggressive incompatibility program in their kidney division. And today she's going to share with us their blood group incompatible kidney transplantation experience, I assume. All right, very good.
So I'd like to start off with just sort of giving the current state of affairs of transplant. These are some statistics from the National Kidney Foundation as of June of 2013. Currently there's a significant amount of people that are waiting for life-saving organs, and the majority of those are waiting for kidney transplant. Last year there were roughly 16,800 transplants that took place in the U.S., and of these, 11,000 came from deceased. I'm sorry. I don't know.
Yeah, keep talking. Why don't you use that?
Yeah.
So of these, 11,000 came from deceased donors, and roughly 5,700 came from living donors. As we can see, this is the OPTN SRTR data from 2011, and the most disadvantage of our patients that are on the waiting list are those that are in the minority of the population, those with blood type O or B, and those that are highly sensitized, as noted by panel reactive antibody percentage. Up to 25% of patients that are on the deceased donor waiting list have PRA above 80 to 100%. And just for you all to know, PRAs are basically indicative of HLA sensitization, either by previous transplantations, pregnancies, or blood transfusions. And those that are the most sensitized are the least transplanted. This is some data from the HRSA website noting the current waiting list and also the significant sort of discordance between those that are on the waiting list and those that are active. And a lot of factors can contribute to why a patient is inactive. Some of the most important ones are that perhaps their workup is incomplete. There's always insurance issues. We're constantly challenged with BMI cutoffs in our patients as they are growing, as well as their waist circumference is growing. But the majority of patients, 35%, are actually just too sick to be transplanted. And when you're looking at the half-lives for adult kidney transplants, on average, living donors have a half-life of roughly 14 years, whereas deceased donors are anywhere from 9.5 to 11 years. So that sort of begs the question, should we be transplanting patients that have an expected survival that's less than 9 years? So what are our options to try to increase transplantation? Well, I don't know if any of you all saw this article in Wall Street Journal. This was published by two economists, Gary Becker and Julio Elias, and they sort of view the challenge that we have with the supply-demand issues with organ transplant as just simply economics. And by actually increasing the market and making it a marketable issue, we potentially can downgrade that gap. I mean, this is fraught with ethical issues, and I'm not going to get into all of those. But there's got to be other ways that we can increase our transplantation potential. And most of those we're already doing with the increased utilization of donation after cardiac death, socially high-risk patients, expanded criteria donors, and also improved ICU care. That's all increasing our utilization of deceased donation. As far as living donors, it's interesting to note that around a third of donor-recipient pairs are actually blood group incompatible. And it's estimated 6,000 on the deceased donor waiting list have a willing and able donor, but unfortunately are blood group incompatible. So some of our options that we can utilize to increase living donors are going to be paired kidney exchange, HLA desensitization, and then blood group incompatible transplants. And often, more times than not, it's a combination of all three of those. So as far as the living donor options go, they're basically the classic one is the direct donation. You have a healthy individual that's willing to donate, they're blood compatible, and they have a negative cross match. And with all those three hurdles crossed, you can go ahead and have a successful living donation. If that isn't an option, then paired kidney exchange becomes something that can be pursued. And there are various options in terms of, thank you.
Should work. Go ahead.
I think so. Anybody, can everyone hear me? Okay. And, you know, obviously there's various exchange options that we're all familiar with. Well, some of the challenges that we can face with paired kidney exchange is that it still is a disadvantage for blood type O. And it's often a complex and expensive collaboration. Is it a fair trade? That's always sort of an issue that comes up. There's always those that can renege on their promises and have fallout. And then the candidate antibody screening and reporting is not always uniform from one institution to another. So with all of that in mind, the role of blood group incompatible transplantation comes to light. So just as a brief review, there are four main blood groups, AB, AB, and O. And those are dependent on the various antigen expression that's seen on the red blood cells, with group O having none and AB having both A and B antigen expression. And when we look at blood group by race, we note that the majority of people are going to be type O or A, with blood groups B being more common in Blacks and Asians. And so it's no surprise that the majority of our patients on the kidney transplant list are predominantly blood type O, having the longest wait time. Antigens of ABO are not only expressed on red blood cells, but also platelets, lymphocytes, epithelial, and endothelial cells. And ordinarily, blood group incompatible kidney transplants precluded because of these blood isoagglutinins that are present that lead to hyperacute rejection and allograft loss. So the majority of ABO incompatible protocols are going to be geared towards minimizing this isoagglutinin effect. There's some outcomes that or trends that have been noticed when looking at ABO incompatible transplants. It's thought that blood type O recipients are a little bit more immunogenic or antigenic as they have a higher level of anti-A and anti-B immunoglobulin G. And that immunoglobulin G is specifically thought to be responsible for the acute antibody-mediated rejection as well as chronic rejection. Previous studies have showed that the initial titer, rather than the antigen targeted, was more correlated with the risk of antibody-mediated rejection. So blood type O sort of classically being a little bit more antigenic. Well, what about the other blood groups? Well, we can look at blood group A, and it can be subtyped into A1 and A2. And A1 usually has a larger antigen density, and compared to A2 is more antigenic. So if we look at the immunogenic risk based on antigen expression alone on red blood cells, O is the highest, followed by A1 and B, which are equivocal, and then least is A2. So given this less antigen density that's noted on A2, often successful transplants can occur without prior desensitization. So I'm going to sort of start with doing a historical perspective on the various protocols that have been utilized. And all of the protocols sort of focus on three main things: the reduction of circulating ABO antibody titers, adjuvant therapies with splenectomy, which has now been replaced by Rituximab and IVIG, and then induction and maintenance immunosuppression. So the main way that we remove these circulating antibodies from the system here in the United States is with pheresis. And for just a brief reminder, our plasma component is what contains most of our immunoglobulins, albumin, as well as our clotting factors. And so plasma is separated, discarded, and then that replacement volume is given back in the form of albumin or plasma. Plasma being donor blood type specific or AB specific in order to minimize the exposure of more isoagglutinins. It's the cheapest of all three of the methods that's out there, and it sort of removes immunoglobulins in bulk. But the disadvantage is that you remove some of the beneficial components of plasma, mainly the coagulation factors, hormones, and antiviral and antibacterial IgG and IgM. Double filtration plasmapheresis, as the name implies, involves both that plasma separation component and then a second filter that more specifically targets IgG and IgM. And it takes advantage of the size discrepancy to try to maintain much of your albumin while discarding the IgG and IgM, meaning that less replacement volume is necessary. Double filtration plasmapheresis is mainly used in Japan in their ABO incompatible protocols. And then finally, there's immunoadsorption, which involves a more specific means of targeting either HLA antibodies or ABO antibodies. And the cost of this is around 2 to 3 times that of regular pheresis, and it's only performed in Europe. So the majority of the experience that's been had in ABO incompatible transplants came out of Japan, mainly because of the need, sociocultural reasons why they don't have as many deceased donor options. And this data has been utilized in the US as well as Europe to form the majority of their protocols. And currently in Japan, ABO incompatible transplants account for 20% of all of their living kidney transplants. So this is the usual protocol. Back in the 1980s, 1990s, majority of the time they were using the double filtration plasmapheresis in order to remove those circulating immunoglobulins. Immunosuppression was done in the form of alentizumab. Triple sequential immunosuppression is in the form of cyclosporin, azathioprine, and methylprednisolone. And splenectomy was performed at that time. Well, with the advent of Rituximab, things changed, and so splenectomy was no longer routinely performed. And of note, no post-transplant antibody removal, i.e. in the form of double filtration plasmapheresis, was performed, except if there was a rapid rise in their titer 1 week post-op or if there was biopsy-proven AMR. So this was a study that was published in 2004 highlighting the outcomes of ABO incompatible transplants between 1989 and 1991. And as you can see, there were around 441 cases of ABO incompatible transplants. These were matched for historical controls of ABO compatible transplants. And when evaluating for graft survival as well as patient survival, there was no statistical significance or statistically significant difference noted when assessed at 1 year, 3 year, 5, 7, and 9 years post-transplant. Again, this protocol involved splenectomy, but with the advent of Rituximab, things changed. Rituximabs are monoclonal antibodies specifically targeting CD20 markers on B cells. And it results in antibody-dependent as well as complement-mediated cell toxicity. It's classically used for B-cell non-Hodgkin's lymphoma, and usually at high doses causes significant B-cell depletion. Well, in our ever involving quest to try to minimize the immunosuppression of our patients, the question was raised as to whether or not that was just an excessive dose to be utilized in renal transplant patients. So studies were done looking at the pharmacodynamics and pharmacokinetics of rituximab. This was a study that was performed in 2004 that looked at actual pre-transplant patients. These are patients on dialysis. There were 9 patients, highly sensitized with PRAs greater than 50%. And it was a dose escalation trial that looked at various doses of rituximab and looked at the mean rituximab plasma level as well as the effect on B-cell suppression. And what they found was that there was a significant reduction of the panel-reactive antibodies. There was also a decrease in the mean fluorescence intensity that was noted, as well as a change in the histogram architecture on ELISA, implying that there was a loss of specificity for some of these antibodies. So the results showed that low dose, 50 milligrams per meter squared, was as efficacious as high dose, and it was an effective agent for reducing high titer anti-HLA antibodies, and a pretty durable response up to a year out. So this was a study that looked at 5 patients. This was in Japan, in Tokyo, looking at those that were highly sensitized with anti-HLA antibodies as well as blood group antibodies. They started receiving triple sequential immunosuppression 7 days preoperatively. They all underwent the removal of antibodies with double filtration plasmapheresis. Low-dose rituximab was given at the time of transplant as well as splenectomy. And their goal was to look at the response of rituximab on splenic B cells as well as peripheral B cells. Looking at this, they did fairly well. Only 2 patients had episodes of antibody-mediated rejection within the first 3 months, and their serum creatinine at 2 years was quite good. So looking at the effect of rituximab on the splenic B cells, these are immunohistochemistry stains, and even at low doses, you can see that there was a significant depletion of the B cells. CD138 was also utilized as a marker, but rarely is that seen in white pulp, and so therefore there was no significant difference seen. As far as what it did to the peripheral B cells in the blood, even at low doses, 10 milligrams per meter squared, there was a decrease in B cell counts. However, this was the patient that did have an episode of antibody-mediated rejection, received an additional dose of rituximab, and still had fairly consistent B cell suppression. But even at doses as low as 15 milligrams per meter squared or 35 milligrams per meter squared, there was a significant drop in B cells. And although B cell titers did rise, they very rarely rose to the point pre-rituximab. So the conclusions of those studies were that doses as low as 15 milligrams per meter squared causes complete circulatory B cell depletion. And since the highest rates of acute antibody-mediated rejection are usually seen 3 months after transplant, the effects of low-dose rituximab seem to be appropriate for desensitization protocols. Continuing with the Japanese experience, this was a study that looked at 408 patients that were underwent living-related kidney transplants. There are around 280 of those that were blood group compatible, 63 that were incompatible with a splenectomy, and then 50 that were incompatible with rituximab. And overall, you can see Group C, that was the group that was incompatible with rituximab, overall had very good graft survival rates with a median time to follow-up of around 34 months. And continuing that trend out, 5-year graft survival tended to be better in the rituximab-treated patients. So highlighting some of the studies in Europe, this was a study of 60 patients in Sweden and in Germany, 3 centers overall. They received high-dose rituximab, followed by the usual triple sequential immunosuppression, and immunoadsorption was utilized for antibody removal. The Swedish group performed continued immunoabsorption post-op, regardless of their titers, but the facility in Germany only utilized it if there was a significant increase in the antibody titer post-op. And what they found was, compared to their ABO-compatible transplants, overall graft survival and patient survival was quite good. What was interesting was that the reported IgG antibody titer was quite variable. And the authors really couldn't figure out an exact reason why that was so, other than potentially that there's a lot of inter-observer variability in the reporting of antibody titers. And this was seen in other studies. And I want to just briefly talk about titer assessment and reporting, because it obviously has significant implications on our treatment plans for our patients. As you all know, the tube dilution method is the most commonly used method for assessing titers. Usually a positive agglutination reaction will lead to a positive analysis. And most of the time, this is detecting immunoglobulin M as well as total isoglutenin titers. But this is not always consistently reported in the literature as such. We know that the immunoglobulin G is what's largely responsible for the antibody-mediated rejection and chronic rejection. And so given the inter-observer variation, usually a titer that's reported as 1 to 128, may represent a titer of 1 to 64 or 1 to 256. There are other, a little bit more sensitive means of assessing titers. This is a column agglutination test, but it also has its challenges in terms of having some inter-observer variability. And the most specific means would be flow cytometry. However, it unfortunately has a relatively high cost as well as turnaround time. Some of the observations that have come out of titer assessment is that obviously we need better ways of assessing it. Although center-specific protocols vary, generally you want a titer of at least 1 to 32 before taking the patients to the operating room to minimize that incidence of acute antibody-mediated rejection. And most of the time, immunoabsorption or plasmapheresis will be performed to obtain a goal of less than 1 to 16. Although it's felt that an initial titer greater than 128 predisposes to an increased risk of antibody-mediated rejection, that really hasn't been seen as much, and it's thought to be secondary to the successful attempts of desensitization. So, turning to the American experience, this was sort of the protocol that was adopted initially by Johns Hopkins. And it also involves the utilization of removal of antibodies with pheresis. They specifically used anti-CMV antibody pooled immunoglobulins, thought to be potentially less immunogenic and less variable. Initial studies used the high-dose rituximab. Induction was with docetaxel, and they also utilized standard immunosuppression. Their pheresis therapy was continued post-operatively, and overall you can see that there was a nice predictable decline in their isoglutenin titers. Just as a review for you all, IVIG has numerous immunologic effects, mainly modulating the immune system response, neutralizing anti-idiotypic antibodies, reducing antibody formation, and inhibiting complement-dependent injury. So the results showed fairly good outcomes. This is sort of the mean results of these 6 patients. Their initial titer pre-operatively, their initial titer prior to any type of therapy, pheresis, et cetera, was on average 1 to 80. The titer at the transplant time was 1 to 8, and they did not have a significant rise in titer post-operatively. At a median follow-up time of 12 months, most of them had a very good serum creatinine. What was interesting to note on their protocol biopsies was that they started having the appearance of positive C4D staining without any other evidence of antibody-mediated rejection. Only one patient was noted to have acute cellular rejection at 3 months. Right here, which was just found sort of by fluke. They did not have a rise in their creatinine. And looking at their pathology slides, you can see day 4, there was no evidence of rejection on light microscopy. They did have some trace areas of C4D staining, which became a little bit more diffuse and prominent, linear and peritubular capillary deposition at 1 month. 3 months, there was still that persistence of C4D that was noted, as well as 6 months. So the C4D, in and of itself, is not indicative of antibody-mediated rejection. But as a reminder, signs such as microthrombi, mesangiolisis, and peritubular capillaritis are more supportive of a diagnosis of antibody-mediated rejection. So the C4D staining was commonly seen in ABO incompatible transplants without graft dysfunction, as compared to those that are HLA incompatible, where C4D is positive and is usually related to graft dysfunction. So the principle of accommodation basically is that they've observed that in ABO incompatible kidneys, there is very commonly C4D staining that's present, and it does not seem to impact long-term graft function. The Mayo group also published their experience with ABO incompatible transplants. They utilized higher doses of Rituximab, and their overall outcomes, 1-year graft as well as patient survival, were slightly lower in the ABO incompatible recipients, but no significant difference was found in GFR or serum creatinine. So this is the WashU protocol that we use. We've been doing ABO incompatible transplants since 2007. And usually we always like a starting ABO titer less than 1 to 128. Rituximab low dose is utilized roughly 4 weeks prior to transplant, and immunosuppression in the form of Myfortic is started at that time, as well as infection prophylaxis. Repeat isoagglutinin titers are obtained, and pheresis therapies basically are assessed in terms of how many we'll need. We expect a 1 dilution drop per treatment, and our goal preoperatively is a titer of 1 to 8 to 1 to 16. IVIG 10 grams is administered after each pheresis to prevent rebound of antibody, and then a larger dose is given after the last session of pheresis in order to replace the hypogammaglobulinemic state. And with the current use of biocompatible membranes, we don't see as many reactions, but usually we do stop their ACE inhibitors or ARBs. So on the day of transplant, they all receive immunosuppression induction with thymoglobulin for a total of 6 milligrams per kilogram. Started on methylprednisolone, given high-dose Cellcept, and then continued on Myfortic 720 BID. And their tacrolimus levels are titrated to a goal of 8 to 12. And very rarely is any pheresis performed post-operatively unless there's signs of antibody-mediated rejection or if there's a significant rise in their titer. And overall, the outcomes have been fairly good. There have been 24 patients that have had ABO-incompatible transplants. Their graft survival, patient survival is comparable to ABO-compatible. And all but the exception of 2 have a creatinine less than 2. Looking at sort of the bigger picture in terms of outcomes across the board in the US, this was a paper published by Montgomery in 2012 looking at ABO transplantation between 1995 and March of 2010. And a total of 738 ABO-incompatible transplants have been performed at 280 centers. So it represents 1.5% of all living donor transplants, in stark comparison to the 20% that's seen in Japan. They did variable subgroup analysis looking at donor blood type, trying to see if there was any significant difference between A2 versus A1 donors. Also to see if there was an overall higher IgG assessment in blood type O. And then looking at the outcomes based on transplant center volume. The median follow-up time in years was roughly 5. Looking at recipients overall, the majority were blood type O. Unfortunately, not all were subtyped for A1 or A2. And in terms of center volume, 11 centers did on average 15 per year. The majority of centers did roughly 5 a year, and then 43 centers that had only performed 1. Looking at the recipients, they're highly sensitized, as we well know. They've had more years of renal replacement therapy, more likely to have a previous transplant, and have a positive cross match with their donor. So these are the results. And overall, looking at patient survival for those ABO-compatible and ABO-incompatible, you can see that the outcomes were roughly the same at 1, 3, and 5, and 10 years. Looking at the graft loss and graft outcomes, it seems like there was a little bit of a poor outcome in ABO-incompatible transplants. However, this was thought to be secondary to graft loss that occurred mainly in the initial 14-day period post-transplant, where they're at the highest risk of antibody-mediated rejection. And after this period, their overall graft survival was comparable. Those subgroup analyses that were done, there was no difference between A1 and A2 donors, no higher graft loss between O and non-O recipients. And as far as center volume, there was really no difference. So short and long-term outcomes remain the same regardless of how many you do. And this suggested that there was sort of a minimal learning curve as long as the necessary facilities and personnel are available. Well, what is the cost of ABO-incompatible transplant? On average, these are sort of the numbers that I got from WashU. Plasmapheresis with albumin exchange roughly is $5,000 per exchange. And for the most part, patients will undergo 3 to 4 sessions of pheresis before their transplant. High-dose IVIG is around $5,000 for a 2 mg per kg dose, low dose being a little bit less. Rituximab, the conventional dose, 375, is $7,000 a dose. We utilize the low dose, 200 milligrams. So on average, the increase of cost is roughly $24,500, and that's not factoring in having the patients come in several days before, labs, et cetera. But when you think about the prolonged course and cost of dialysis, then it is something that should be considered. Looking from an infection standpoint, there has been increased incidence of BK viremia in those that have been desensitized with IVIG and Rituximab. And this was some data from Johns Hopkins that looked at ABO-incompatible as well as HALA-incompatible. And they found that there was a significantly increased risk of BK allograft nephropathy in those that were ABO-incompatible. Other studies looked at the adverse events in ABO-incompatible patients. This study showed actual increased risk of viral infections across the board. But this study by Kathwaji et al. That was done at Cedars-Sinai showed that there were equivalent rates of viral, bacterial, and fungal infections. And the overall freedom of infection was relatively the same. So some conclusions that we can draw. Successful transplantation across blood group barriers can occur. Usually, the success is increased if the baseline titers are at least 1 to 32, ideally less than 1 to 8 at the time of transplant. C4D staining is innocuous in ABO-incompatible transplants, and the absence of any other histologic abnormality represents accommodation by the immune system. It does require significant resources and diligent personnel, but one must balance the ethics and economics from several perspectives. And that's it, if you all have any questions.
Angelina, go back several slides. I think it was the meta-analysis group. Okay, right there. At your very last bullet point, after this period, everyone had a relatively, no, there was something that talked about positive cross matches.
With
Some patients were ABO incompatible and HLA incompatible.
Okay, so, well, correct me if I'm wrong, if you do a cross match on an ABO incompatible pair, isn't the cross match going to become that positive? Well, that's the question. This positive cross match after you've undergone the conditioning regimen?
no, I think it was before.
I just would assume that the cross match is going to be positive in near 100% of the pairs. I don't
Well, it
understand.
depends on what kind of cross match you're doing. If you're doing a flow, sometimes cross match, then you're looking at specifically a HLA antibodies. Right. I mean, the old style, yes, where it was, you looked on the lymphocytes and you said it's serum, that would be positive in every case, as long as the blood group antibodies were positive, but who knows what this was.
I mean, that's a practical matter. You have, I'm sorry.
Sorry.
Go ahead.
Positive cross match with an ABO-incompatible HPRA. Are you also doing it with known DSAs, or are you?
Yes. The majority of the time, I mean, they do have HLA antibodies as well. So this protocol is also used for desensitization. It's very similar to the protocol that we use for desensitization at WashU. So we're sort of hitting two issues at once.
So the first option in all patients would be a paired donor exchange. You obviously exhaust that option before you go to this one, right?
Right, yes. And so the majority of time we are using that combination of utilizing the paired kidney exchange and then providing some desensitization. And if all else fails, utilizing the ABO incompatible. And there's some people that are very keen on, I want to donate to my loved one specifically. And so this becomes a viable option at that point.
Things set in place here that we can do daily ABO titers.
Blood bank would.
How about daily PRAs or daily donor-specific antibodies? We don't have that in place now.
Okay.
What would be what's the turnaround time then?
Blood's there by the morning. I mean, but
First thing in the morning and or the night. What are the actual AMR rates? I saw, we're talking about rates are higher. What are the actual numbers?
Right. So, unfortunately, I didn't include that slide. In the Montgomery study, let me see if I actually put it here. No, I didn't. The rates were around, I believe it was 2 to 3% of the ABO compatible compared to. The WashU experience, we actually haven't had any antibody-mediated rejection. The reasons for the 2 patients that have elevated creatinines were mainly a consequence of BK nephropathy.
So are you guys doing protocol biopsies?
No, we're not. At WashU, we weren't. We do the usual BK surveillance during the first year, checking monthly BK and CMV assessment. And then after that, we just sort of monitor. But no, we're not routinely performing the protocol biopsies.
How frequently has that, out of the roughly 24, how many have required plasmapheresis after transplant?
Just one patient did, for a substantial rise in their titer. Went from 1 to 8 to around 1 to 128. So pheresis was performed at that time.
And then you get the titer back down, and then it stays down after that second?
He actually got an additional dose of Rituximab, 200 milligrams.
For how long do you recommend monitoring the titer post-transplant?
So usually we do it while they're in the hospital, post-op on a daily basis, and then we check it on a weekly basis for the first month. Honestly, though, it's not that we actively intervene, even if it is rising, because most of the time those rise in titers post-operatively are a poor predictive value for actual antibody-mediated rejection. So clinically, if there's something going on, then we get a little bit more aggressive biopsy, et cetera.
And you mentioned that there were more surgical complications. Can you describe what the nature of those
Sure. So the majority of the surgical complications are going to be mainly related to bleeding. Even though we try to do a good job of replacing them post-pheresis with FFP, and their coags are usually normal prior to surgery, we've found that their bleeding rates are higher. Their post-transfusion rates after transplant are higher as well.
And return to the operating room for bleeding?
No, no. Just the usual post-operative bleeding.
Now, roughly 24 have been done, and you've been intimately involved with some of them?
No, well, from my experience over the last year, there have been 5 patients so far that we've done that have been ABO incompatible.
And you've been there on day 1, and so what is the stress level amongst the team when you're doing one of these? Or is there? It's like, oh, no big deal, put them through the protocol, and they go through their little stations,
right.
And then get transplanted.
No, I'd say that there's definitely, there is a stress component, but thankfully there are a lot of very seasoned and experienced people that are involved with it, all the way from our HLA lab to the people that are doing the pheresis, et cetera.
And who are doing the pheresis? I assume it's the blood bank personnel.
Actually, we are. So right, and the pheresis that we're able to supply, we utilize our next stage dialysis machines. We can run high blood flows. We can utilize their fistulas. There's no need for extra catheter. And because of that, we are able to shorten their treatment time. So we can do a 1.5, 2 liter plasma volume exchange in a matter of 2 to 3 hours compared to an 8-hour treatment. So that significantly impacts patients because they're not hooked up to a machine for a prolonged period of time. And we've overall had some good outcomes. Probably the most severe adverse events related to the pheresis are some patients that can become quite symptomatic from hypocalcemia. So those that have had subtotal parathyroidectomies and have had a lot of issues with secondary hyperparathyroidism in the past can become quite hypocalcemic. But for the most part, the pheresis sessions are well tolerated. And there is always a sort of a mad push to get the HLA titer back from the lab, or I'm sorry, the ABO titer back from the lab. So that's always a little stressful for the lab.
So when you're pheresing, are you citrating or heparinizing?
So if the traditional method is used, usually they are receiving either heparin or citrate. With the next stage machines, because we're able to run such a high blood flow volume, we usually don't have clotting issues. So we're able to bypass the citrate or the heparin.
I would assume you don't see the hypocalcemia.
As much, exactly, yeah.
Cold machine, and they do it very fast.
Yeah, they use the code.
Does the Japanese experience, it's long enough now, do they have an experience on tumors? Because you're depleting B cells and T cells for quite a long time.
I'm looking at that. No, it's a good question, and honestly, I didn't look specifically for that. Right, to assess that. Most of the studies that I saw mainly were highlighting the infection complications.
Which I'm a little surprised. I guess it was your last slide, the Cedars-Sinai, where there was no significant difference in infectious complications with whatever they said the two groups, not knowing what the control group is. Is that a control group who received induction therapy also, or what do we know about that control group?
Their control group in this study was ABO-compatible transplants. So they had undergone no significant desensitization.
That's a lot of immunosuppression.
Yeah, that's why I'm not going to question it. I'm sure that it got published in a peer-reviewed journal, but I would just always assume that the infectious complications are going to be higher.
Yeah.
And does it impact the duration of the antiviral prophylaxis?
So it doesn't. CMV prophylaxis is the usual, and then Bactrim is maintained indefinitely in most of our patients. We use PCP prophylaxis for the length of their transplant, not necessarily because we're concerned about the PCP risk after a year, but more so because we've seen decreased rates of gram-negative sepsis and urinary tract infections with the utilization of Bactrim prophylaxis. So all of our patients are on that.
And that's just universal for all of the patients in general, or how long are you doing?
All of our patients in general all receive Bactrim for life.